Well, good morning. It's great to be back in the UK. I've had a few days at Gimba. It's several hospitals in and around London. And the thing that I think I've found that's really significantly different between the UK and the US is that we now have a new chief clinical officer. And if you can't see this, that's our President, Obama. And so the fact that you have a burning platform to change, guess what? We've got one that's even worse. So God help us. But what I want to do this morning is talk a little bit about actually some of the results that I started talking about 2 years ago. We actually have results now, so that's a good thing. I'm all for using lean to drive results in healthcare performance. And I'm going to talk about a sort of a plan. And where we've gone at this stage of the game is really to think about our lean activity as transformational. So how do you transform your whole organization? You know, because we did Kaizen, we did value stream, but how do you actually transform every single person, every staff member, every physician in your organization to one that is focused on continuous improvement? And that's what I think that's really the challenge now for those of us on this journey. So I want to talk about sort of our thinking about what that transformational plan actually looks like to continue to bring lean into healthcare. So whenever Toyota starts to look at a problem, they look at it from three perspectives, right? So it's purpose, process, and people. So those are the three things we're going to talk about in this transformational plan this morning, is purpose, process, and people. Because I think that if you carefully look at each one of these components, that it's possible that you can transform your organization. So that's where we're going to start. This is the mountain of improvement. Okay, so we're all trying to get up this mountain. And at the top of the mountain, guess what? We get our people to change their habits. So that's the cultural change we're after. But there's a series of things. This isn't just about a methodology. It's not just about leadership. It's not just about goals. It's about a whole series of things. And frankly, if you don't have all of those things, it doesn't happen. It just doesn't happen. And I've been around to many hospitals now in North America, and everybody's struggling with different components of this purpose, process, and people mountain of improvement. So let's talk about some results because, you know, this is about results. There isn't any reason to do lean if you're not improving results for customers. And this is an inpatient redesign unit called the Collaborative Care Unit that we've been working on for 2 years now, Thedacare. And as you can see, we started out with the problem in the inpatient care unit of this hierarchical structure, disjointed care, lots of mistakes. We got lots of people that are heroes. They're out there trying, okay? But the reality is the processes are so broken that we can't be reliable. So we have multiple care plans. So the vision of this new unit, and by the way, we worked on inpatient care improvement for a number of years, using lean and even before lean, and we couldn't fix it. We couldn't improve it. And so what we decided was it was time to just blow it up and start over and innovate using the lean tools. So our goal was, on the right-hand side, let's get a single plan of care, okay? One plan developed by the team in the room with the patient. Okay, so that's the vision. One plan developed by the team in the room with the patient. Is that possible? That was our question, is that possible? So this is what we did, and it's, you know, the thing about lean, which is interesting, is that lean is not about technology. All right, so the only technology you see in this redesign is different colored sticky notes. That's it. All right, because it's not about technology. And this is basically the redesign of the inpatient care unit. And what you can see is red stickies on top are actual toll gates. These toll gates are how the patients actually move through the system. We have a series of criteria, or poka-yoke, that each patient has to go through before they can move on to the next toll gate of care. Now, these toll gates are different depending on the diagnosis. So if you have congestive heart failure, that's different set of toll gates than if you have pneumonia, is different than if you have septicemia. So a simpler way to look at this is we have 5 toll gates for each clinical condition. And what we're doing is saying, the patient, we're asking the question, is the patient able to be progressed through the care process? And if not, then many PDSA cycles are being done. And guess who's doing those PDSA cycles? It's the nurse, because now the nurse becomes the process owner of this care process. So within the first 90 minutes, if you actually go back to this picture, within the first 90 minutes of the patient's admission, the nurse, the doctor, the discharge planner, and the pharmacist all meet at the patient's bedside with the family and the patient and develop a single care plan within the first 90 minutes of every admission on this unit. And then the nurse actually becomes the care manager to move the patient through these toll gates. So you might imagine now we have a significant difference in roles and responsibilities of these caregivers, right? Because now the nurse is actually calling the doctor saying, "Doctor, we didn't meet the 5 quality criteria to move the patient to the next toll gate. So you need to do, X, Y, Z." So now it's the nurse calling the doctor, telling the doctor what to do. That's a very interesting change in roles. And it has been the hardest part of this work is actually to change the roles and responsibilities of the nurse, the doctor, the pharmacist in the care process. But again, if you think about it from a lean perspective, what we're doing is we're creating a multidisciplinary team with a process owner to improve performance. All right, so what about the results? If you look at the first column there, this is pre-collaborative care, so 2006. You can see we had 1 medication reconciliation defect per patient admission. We had very poor quality bundle. The quality bundles are what we report to the government. So it's, did you get your antibiotics within 4 hours? Is your oxygen saturation greater than 90% if you have pneumonia? Those sorts of things. Patient satisfaction was only 68% of the patients actually rated us 5 out of 5. So we certainly had a lot of improvement to do there. You can see the length of stay, case mix, and cost. So at the end of 2007, that was 11 months of piloting this new performance, this new unit. You can see we had 0 defects, basically 0 medication reconciliation defects. We had 100% compliance of the quality bundles. And actually it says we didn't have 100% quality bundle compliance with pneumonia, but in fact that was an issue with our electronic health record. Our electronic health record was unable to send the information to CMS, the Centers for Medicaid Services, so we couldn't count it. The patient actually got the appropriate care, but our electronic health record was unable to send the information correctly to the government, so we couldn't count it. In fact, all of our quality misses have been related to our electronic health record. So if anybody thinks that the electronic health record is going to save medicine, I've got data that shows it's just the opposite of that, okay? So anyway, patient satisfaction went up to 90%, 5 out of 5. You can see the difference in cost there at the bottom, about a 21% difference in direct cost in this unit. And then this is the 2008 results. Again, the quality results, 0 defects on medication rec, and these patients all met the criteria, but we couldn't count them because of the electronic health record. And then look at the difference here in total cost between the non-collaborative care units and the collaborative care units. That's about a 25% difference in total cost of care. And of course what that means, the length of stay has come down significantly, right? The quality has improved significantly, And so that's the reason that the total direct cost per case has dropped significantly. And we showed this data to the doctors because, the doctors really didn't like this. The doctors really didn't want to do this. And we showed this data to the doctors after the first year, and they looked at it and they said, well, this is a better process. This is just simply a better process, so this is what we need to do. And it's, I think, a very important learning that the physicians really do respond to data. And when you can show them absolute, evidence that, zero medication reconciliation errors for 2 years, I mean, who in the world has zero medication reconciliation errors for 2 years? Now that's about 2,500 patients over that period of time. So we've made no errors on 2,500 patients. Here's an example. We were talking about Flinders Hospital in Australia earlier. I was down there last year, and what they've done is to put these smocks on their nurses when they're delivering medications. And what the smock means, this blue smock, means you can't interrupt me. You can't interrupt me. And so if you can't interrupt me, guess what happens? Medication errors drop by 50%, okay? And medication omissions drop by 50%. Now, they've subsequently found that as they've gone on with this, that they've dropped medication errors by 85% using this very simple, here's the sequence, don't interrupt the sequence kind of activity. Door-to-balloon time is something we've been working on for a long time. This just goes to show you now that we're down to 37 minutes. This is after multiple value streams in Kaizen. 37 minutes actually is, say, clinical term. So this is what's been happening over the last few years at Thedacare. And actually this year, that 2009 budget, they're actually tracking at 3.5% productivity improvement. Now I will tell you, every 1% improvement in productivity equals $2.5 million improvement to the bottom line of the organization. So over the last few years, we've been able to improve operating margin. We've doubled the operating margin of this organization. This year, through June, Thedacare is tracking at a 6% operating margin. Now, to give you a context for that, in the U.S., the average hospital has a 1% margin. Okay, 1% margin. So 6% margin in this economy is frankly absolutely unheard of in healthcare. And so it's because of this, because the majority of our costs are in labor. And as we improve our performance, we reduce our cost by improving our productivity. Okay. So those are just a few results. I've got lots and lots of results. We could talk about them all day, but let's talk about, so how do we actually make this happen? Because now we know it works. Dan said he thinks it works. I know it works. Gary Kaplan knows it works. Patty Gabow at Denver Health knows it works. I mean, it works. So let's stop talking about whether it works or not. It works, all right? So let's talk about how we're actually going to do it, because that's really the issue. If we could get everybody to do this, we could save trillions of dollars across the world in healthcare, and that's really what we need to do. So the first thing is we need to talk about the purpose of why we exist. Again, we're talking about purpose, process, people. Purpose, process, people. So why do you exist? This is why Thedacare exists. I would guess you have missions that are fairly similar to this. So what is the strategy that you are driving in your organization? What's the strategy? For Thedacare, for the last 10 years, it's been we're going to create measurably better value for our customers. That means the highest quality at the lowest cost. The highest quality at the lowest cost. So how does that translate into your organization? What is your strategy to deliver better value to the customer? Because when we really boil this down from a purpose perspective, that's our job, is to deliver better value. That's our job. And it's not just about quality, it's about cost too. We have to deliver higher quality at lower cost. And that starts with, from an organizational perspective, being able to set a set of goals, all right, that you can translate to everyone in your organization. What are your goals? See, the problem is, and Dan very well outlined that, is that we have 100 goals. I go into a hospital, I see 100 things on the wall. How can we get 100 things done? There is no possible way we can get 100 things done. So what I did, 9 years ago was say, or 10 years ago, we're only going to do, there's only going to be 3 things. Now, I'm not sure what they are yet, okay? Because it took us actually several years to get to this level of detail about what really matters. But we're only going to have 3 things. And so even today, these 3 things now are, we're going to reduce defect rates by 50% year over year. So defect rates include things like wrong-sided surgery, like medication errors, like surgical infection rates. We're going to decrease those because those are all defects from a customer perspective. We're going to decrease those by 50% per year. We're going to improve productivity. I've just shown you productivity data. We're going to improve productivity by 10% every year. Now, the data I showed you is that we didn't get to 10%, did we? We didn't get to 10%. But you know, one year we had 4.5%. 4.5% times 2.5 million is a lot of financial improvement. And actually, there are units at Thedacare where we are achieving 25 to 30% improvement in productivity. So when you set the bar high, you reach for the stars. When you set the bar low, you know what happens. And then we're also moving to this engagement piece to be how many of the ideas of the frontline staff are actually being implemented every day? How many ideas are being implemented every day? Because that's a measure of engagement of your frontline workers. And that's what Lean is all about, engagement of your frontline workers. So how many ideas are actually being implemented? So that's it, 3 things. 3 things. But that's not all, okay? You have clear goals, you have a strategy, you have a mission, but then there's a set of processes that we need to put in place. And the first important thing, and actually it's one of the things that I have not seen effectively done here in the UK, is to be transparent about performance. And frankly, it's not effectively done in the US either. So that means, are you willing to publicly report your performance? So that door-to-balloon data I showed you from the cardiologists, you know why that's improved? Because in 2004, they had to report their performance at the Wisconsin Collaborative for Healthcare Quality, and they had the worst door-to-balloon times in the entire state of Wisconsin. The worst door-to-balloon times. And so when they saw that they were the worst, that doesn't make doctors happy when they're the worst. In fact, they called me, several of them called me up and basically said, "You're an idiot to publish this data on a public website because we're going to lose patients and the hospital is going to lose money." And I turned to them and I said, "But you know what? We've been working on this for 2 years and we're still the worst in the state. So I had to get your attention. So by publishing it in the newspaper, I got your attention." And once we got the attention, guess what happened? Those guys figured out how to improve it to the level of the best performance on door-to-balloon time in the United States. So transparency is really important, and we actually report all of our data to this Wisconsin Collaborative for Healthcare Quality. You can go on wchq.org, and you can compare physician performance in almost every physician group in Wisconsin. I wish it was in the United States. We're working on making it national. But this is a state program right now. And what you can see here is Thedacare's performance. You can actually go in and rate these clinics. So you can go in and rate Thedacare versus Marshfield versus University of Wisconsin, all these different places. So this is where the last data set rates Thedacare on all of these different indicators, whether it's A1C control, LDL cholesterol, you name it. And as you can see, they're 1, 2, or 4 in every single clinical indicator. So this is through about 7,000 physicians in the state of Wisconsin. So we're willing to actually put our data out there, even if it's not that great. The other part of the process then, okay, is the actual Thedacare improvement system. So as Dan discussed, we have changed all of the wording to be specific to healthcare. So we don't call it lean. We don't use the Japanese terms. We don't use any of that stuff. We call it the Thedacare Improvement System. And I'm going to quickly just run through what the methodology is that we're using. So it starts with the Hoshin planning process. Toyota calls it policy deployment. And that's what Hoshin Kanri means. But anyway, strategy deployment is the process to embed our strategy across the organization and then target the targets and the means by which we do that. So we start with this concept and we deploy our strategy by the use of A3s. So we use the A3, which is nothing more really than a PDSA cycle. This is just an example of an A3 that's being done, the system A3 for safety, and you can see, it's reason for action, initial state, target state, the gap, what our experiments are, solutions, and then our completion plans. I just found out a couple weeks ago that there are 5,300 of these A3s now actively being worked at Thedacare. So what we've done is we've taken this Hoshin Kanri, or policy deployment process, and deployed throughout the organization 5,300 A3s of problem solving, all the way down to frontline supervisors. So that's the policy deployment, sort of how do you actually make something happen across the entire organization. That's the process we use to do that. As many of you know, the other key component to the method is value stream mapping. I saw good evidence of that, and certainly the Making Hospitals Work book is really about this concept, is how do you actually, take a look at your value stream across the specific patient condition. This is actually what it looks like in real life. This is the cardiac surgery value stream. And at the top, there's a series of stickies. Those are all processes. So is the patient in the ICU, is the patient in the step-down unit, is the patient home. Actually, it's end-to-end, is home-to-home. And then these blue stickies are individual patients. So at any given week, we know exactly where each heart surgery patient is in this process. And if there's a little red tag, it means there's a problem. So the patient maybe had a complication, or there's a problem with laboratory, or there's some kind of problem. And every time there's a little red flag like that, that's the visual cue to do a root cause analysis immediately, that the team does the root cause analysis to decide where the defect is or where the problem is, so that the next patient coming on down the pike here doesn't have the same problem. So we're trying not to pass those defects on as we look at one-piece flow for patients in cardiac surgery. The other core component of what we do is called a Kaizen event. So this is just simply a 5-day rapid improvement event. We take 8 to 10 people off their regular job. They redesign a process, create a new future, run the new process, and create new standard work. So this is before we did the Kaizen in the heart surgery unit, with the blue being the OR tech. It's day. Okay, so that's the OR tech day. So if you had a day like that, how would you feel? After the Kaizen event, this is what she did. Dramatic improvement in movement. So the other thing that's core to the Thedacare improvement system is this thing that we call daily continuous improvement, and this is where we get down to the individual staff members solving problems. These are a series of things that we use. A4 is actionable item log, 6S. So how do we sustain improvement? And we do it by these visual tracking centers. So every unit at Thedacare has a visual tracking center like this. If you go into the ICU, if you go into radiation oncology, if you go into heart surgery, safety, quality, people, delivery, cost. So every place in the institution, you will see safety, people, safety, quality, people, delivery, and cost. Guess where that comes from? Right out of Toyota. Okay. So if you go to the Toyota floor, this is what you're going to see. So what's happening then is those staff members are gathering in front of these boards every day, doing Gemba with their manager, and they're looking very specifically at the details, the performance in each one of these lanes. And we're not looking at 30 days ago. We're looking at 3 hours ago. Okay? what happened to falls on the last shift? Did we have a fall? If we had a fall, did we do a root cause? Did we change a process? Did we create new standard work to improve? Okay? So this is real-time data on every one of those performance measures. And guess what? It all has to roll up into the system 3 things. All has to roll up into the system 3 things. So the A4 is simply instead of 2 8x11 sheets of paper, which is an A3, we have 1 8x11 sheet of paper. So we call it an A4. Very clever, right? So this is a problem-solving process that the staff owns, and almost all of our staff now have been trained in the use of this tool. It's a very simple tool. Problem statement, what are the costs related to this problem? Tell me the 5 whys of the problem. What is the experiment you're going to run to determine whether or not the things have improved? And then what's the new standard work? So every nurse, some doctors, I wouldn't say all doctors, but every nurse, some doctors, and all the technicians can do these A4s, and they're real-time problem-solving events. The other thing that is very important, I think, from a methodology perspective is the 5S. We call it 6S because we add safety. So here's a doctor's drawer before 6S, here's a doctor's drawer after 6S. And of course the point is that now you can find what you need, and we don't have our nurses hunting and gathering anymore, because actually we've found that about half the time their work is spent hunting and gathering. So when we do this, they don't hunt and gather anymore, and they actually are at the bedside taking care of patients. So this is a critical component. All right. So that's just a background of the Thedacare improvement system. But the real issue is what Dan was talking about this morning, is what's the management leadership component of what it is that we need to do to really change. Again, remember that mountain of improvement? So we're trying to get to the top of that, and at the top of that we have habits changed. So that's what we're trying to do. Well, you know what? From a leadership perspective, if you want your staff and physicians to change their habits, that means you have to change your habits, okay? If you don't change your habits, they won't change their habits. So what are those things that we need to change? So look at the right-hand side. In some cases, I've put a white coat on with audiences because I'm a physician. So I put a white coat on, and then I ask people to tell me what that white coat elicits in their mind about leadership. And so I've written some of those things down that people tell me about leadership when the white coat is on. That I'm all-knowing, that I'm in charge, that I'm autocratic, that the buck stops here, that I'm impatient, I'm blaming. Okay? So that's our paradigm. And frankly, that's not just doctors. That's administrators too. Healthcare administrators act the same way as doctors. But that doesn't work. It doesn't work in this new world. In this new world of lean management, we have to become facilitator, teacher, student. Oh, by the way, if you don't know what you don't know, you can't teach. So you got to go learn this stuff, because you can't just expect people to, figure it out. You've got to learn it yourself, which means you got to be on rapid improvement events and value streams and all those sorts of things. I always get a kick out of talking to CEOs when they say, well, we're implementing lean, and I ask them, have you ever been on a rapid improvement event? And they kind of give me a blank stare. They don't even know what a rapid improvement event is, So if the CEO doesn't know that, okay, how can we expect anybody else to get serious about this stuff? So this is the difference in the two leadership styles. So this is a slide from my good friend John Shook, who's really quite a guru and a mentor to me. And so here's his mountain of improvement. And so now the leader, which way is the head of the leader pointed here? Pointed down. Is that the way we think about leaders? I mean, aren't we supposed to be looking up and being these great visionary leaders? Well, this leader's head's pointed down. And what's the leader doing? Helping the staff up the mountain. Right? This is hard work up this continuous improvement mountain. This is hard work. What's coming off the brow of those people climbing up that mountain? So they're sweating. This is hard work. This guy's teeth are clenched. You know? That's a different kind of management style, folks. That's a different manager than most healthcare managers. That's a different manager. But that's the kind of manager that we have to become if we're going to effectively implement Lean. So that means we got to go to the Gemba. We got to go to the place of work. The place where value is created for the customer. And it's not in your office. It's in the ICU. It's in the A&E. It's in the surgical unit. That's where value is being created for our customer. And if you as a leader aren't in the ICU or the surgical suite or the other places, you're not doing your job. In a lean leadership world, you're not doing your job. All right, so what I want to do is show you a video. I have a little video camera. I take it out and I video people, and they don't know I'm doing it. And every time I go now to places, you know, I pull this thing out, they're starting to figure out my deal, so they're always sort of on their best behavior. But these videos, actually, they didn't really realize that I was taking them. So the person on the left-hand side is the vice president. The person on the right-hand side is the manager. And I want you to observe their behavior.
So Karen?
Yes?
Our first question is, how are our patients doing today in terms of risks? Do we have families or patients at risk?
I got a red dot. I'm so excited.
All right.
We have a patient safety issue that showed up today.
Okay.
Anne brought it to my attention. It's an issue of a patient who was on Coumadin.
Okay.
And received supplementary medication for something else related to their head and neck. And those two medications don't do well together, but it was filled in an off-site pharmacy.
Okay.
So, and then the patient was readmitted for an issue to the ER.
All right.
So for a bleed.
So tell me how you're analyzing that problem.
Anne came to me with the facts. Here's what happened. Here was the sequence of events. And because of the readmission to the ER, we called Mike Vila.
Okay.
And said, Mike, what do we do with this? Where do we go? How do we handle it?
So you triggered the medical safety officer.
Yeah.
Did you also start something in the department in terms of a root cause analysis?
Mm-hmm. We're going to root cause it with our physician and our nurses next week. So we've got this scenario documented, but we need everybody at the table.
Right.
We're forwarding Mike the information. He is going to start the conversation with the independent pharmacy. Because apparently there's a couple other pharmacies that he's connected to in this way, that he started those conversations. How do you want to receive the information from us? What would you like to see differently available on our end? That kind of thing.
Okay.
And then he's going to forward our scenario to the folks working on the INRA 3. Because what I'm concerned about is we're an outpatient clinic, but we're considered part of the hospital. And we don't always fill from this pharmacy.
Right.
And our physicians aren't Thedacare physicians. So I'm not confident we're going to get plugged into the work that's happening. So he would help us do that.
Okay, great. So you have a plan in place, and you'll keep me up to date.
Absolutely.
Okay, so what are we observing in this interaction? The vice president is doing what? What's the vice president doing? Questions. The vice president is not there to tell that manager what to do. The vice president there is trying to understand what the problem is. What did the vice president have in her hand? Yeah, her standard work document. So every morning at 8 in the morning, she takes her standard work document for management and goes to every one of her units. This is one of 5 that she's has responsibility for. And she does the same question and answer process with each of her managers. So you didn't hear once in there, well, I think you should do this, did you? What she was trying to do was elicit that manager's response to do the right things by asking questions. That's a Toyota leadership model that you very rarely see vice presidents actually engaged in. And that's one of the things that we're studying very much at Thedacare, is how do we actually change the way that we interact with our folks. So, you know, what we're trying to do here is create respect for that manager, all right? Not telling her what to do, but helping her up the mountain. And we're trying to solve problems every single day. This is one of the things we're doing with all of our folks, just a bunch of training. We do a lot of training with our managers and executives. We have 2-month training sessions for our managers. And all of our executives have to be in at least 2 rapid improvement events or value streams every year. This is interesting, hot off the press data that shows if you're in 5, what this does is shows satisfaction, staff and physician satisfaction on this axis, and the number of lean events that you're in. So as you can see, the more lean events you're in, the more satisfied you are at working at Thedacare. In other words, the more engaged you are as an employee of Thedacare. All right, so one other video I want to show here. This is actually a physicist. The man is a physicist. And again, you're going to see the vice president and the manager and this frontline staff person interact in a different way than what you usually see in healthcare.
We've had issues with patients being on the table, and suddenly we discovered something's not done or something's not right, and that's kind of what I think got us to this point. I mean, we've had smaller issues in the past, but you know, when you have a patient on the table for 45 minutes before you start treatment, it's not good.
So what kinds of things are happening that would cause that kind of a delay or that missed defect?
Well, I know because I was part of each one of those things.
They're just brave enough to surface defects.
Yes, I'm exploring the outer limits of defects in the treatment planning process. Some of the types of treatments that we do on patients are very, I guess, we don't very infrequent. You know, we've done like the Excite lung, we got that I think a little over a year ago, and we've done 7, and Mike has done like 4 of them, and I've done 3 of them. So, you know, basically when I went to do the treatment plan, it was planned correctly, but the setup point where what the therapists see before the image on the spine first, and I originally set it up to start on the actual target, and that's wrong. It should have been started on the spine, and then you go from once you know where you are on the patient's spine, then you can tell the computer, okay, now go move to the target. And so, it did exactly as I told it to do, which was incorrect. It came up, it was right on the target, and they said, unfortunately the therapists are on the ball. I said, this isn't right, it should be on the spine. So, they called us down, they called me down, and we went through it, and I said, I don't know, I need to investigate it. And then after we reviewed the way it was supposed to, the way that the manual tells you to do it, we realized that, we skipped a step, or we did something that we do on another type of treatment that we're not supposed to do in this one.
So you got a great team effort. The team pulled together, the patient's on the table, the radiation therapist says, hey, this doesn't look right, calls you up. Mm-hmm. So there was it was a near miss. We didn't do any delivery of radiation.
We didn't do any delivery. Other than, we imaged the patient, and then we said, this is not right. So, yeah.
So what did that tell us to do next? I mean, when you're looking at
So it got us to a finish. So what was the benefit of doing this for you, Greg?
Other people's viewpoint, and it's not just. I mean, since there's so many people involved, there's little, areas of improvement at each, each individual has their own input as to where things can be improved, and each, physicians, therapists, physicists, sim process, going to MR, going to...
Okay, so what's remarkable about this video, if there's one thing? The guy said, I screwed up. He said, I screwed up in front of the vice president. And what did the vice president do? Ask some more questions. Didn't beat him up. So this is just every day now, okay? When there's a problem, and guess what? That physicist actually did that fishbone diagram himself with the multidisciplinary team. He led the process of getting to the root cause of that problem. That's what we're trying to get to, is to get every one of our staff to be able to talk like he did and to do this kind of root cause work. So what happens? Our medication error reporting goes up, right? Because now we're honest. So we've actually had an increase in medication error reporting, which is fabulous, fantastic. We now are reporting our medication errors. What I do want to finish up with is what I'm doing now in the U.S. and how that may or may not connect with anything that happens in Europe. But what we are doing is through the Thedacare Centre for Healthcare Value, which is what I now lead, we're facilitating the development of this healthcare value leaders network in the U.S. And in fact, if you go on healthcarevalueleaders.org, you can see our website. It is a public website, and we will be posting a lot of information on there over time related to lean learning in healthcare. We're publishing a number of things. Hopefully I will also have a book out sometime in the next few months related to the core components of lean in healthcare. We're doing a lot of work on this transparency, as I described in my talk, and then we are developing a number of other interactive websites. So our goal is to bring lean to healthcare, and we're going to do that with a group of partners with the Lean Enterprise Institute and other partners throughout the United States. And we'll see how we can connect with the rest of the world on this stuff.